Thank you, Dr. Odom. That was great. Appreciate that. I would like to shift now to have some conversation with the committee members who, as we were discussing the charge yesterday, had a number of questions to help clarify our task as we move forward over the next many months. And some of those were transmitted to you earlier. And so maybe we could work from that, but let me just start, and I'm going to try to paraphrase or restate the question, but I would ask the committee members who had posed the questions to add to what I say to make sure that we're asking the right question. The first one has to do with living donors versus deceased donors. The committee's charge and the verbiage clearly focuses or indicates that we should focus our attention on deceased donors. The point was made yesterday, though, that sometimes policies or things that might be recommended relevant to deceased donors may also affect living donors. And so the question was, to what extent should we be thinking about living donors as we're moving forward with the specific charge? And again, before you respond, Dr. Odom, or your colleagues, let me ask the committee members if they want to add to or amplify anything that I just said.
I think Ken Alex has his hand up. I'm not sure if he is wanting to comment here.
No, mine was a question on something Dr. Odom had said. I think Ken stated the other issue already.
All right, so we'll work through this and come back to you, Alex. And Rebecca, just from a technical point of view, I am not seeing the raised hand, so I'm going to defer to you to call in folks if I don't see it through their body language or whatever. So, Dr. Odom or others, any guidance to the committee based on that question?
Gang, any thoughts? My, while we cannot speak for the intent of Congress, and well recognize that there may be some collateral issues if one just simply focuses on deceased donors. The impetus for the mandate with issues of organ allocation modeling and simulation seem to point more directly to issues related to deceased donor allocation and procurement, as opposed to living donors. But I would defer to the committee to, depending on where they see overlap, to use their judgment as to how much of a living donor emphasis they put on. But based on the congressional requests and issues, my sense was the predominant focus was on deceased donors.
Thank you. I think that sufficiently clarifies it for us, and we will move forward under or with that guidance. I would note that we have requested and do expect to have this same type of dialogue with folks from Congress at some point, assuming they're willing. To date, the scheduling did not work out for them to participate in today's session, and so we are trying to work that out for a future session, understanding that there's a lot happening in Washington and on the Hill at the current time, and probably will continue to be for some weeks to come. So we'll deal with that as best we can, but we do want to solicit their input as well. If there are no further questions in regard to this, let me move to a second topic that was discussed yesterday, and there were a variety of questions related to the economic aspects of the study and whether the specific reference is made to costs, but the language also refers to economic aspects more generally, and wondered if you had anything that might help clarify to what extent the committee should be looking at economic issues beyond cost, and if we should be looking at issues beyond cost, if there are anything that you would see as being problematic or that might be off limits in that regard. And again, before you respond, let me ask the committee if they want to add to or amplify anything that I just said. I don't see anything, so feel free to respond as best you can.
I don't know whether we have anybody from the General Accounting Office here, but my sense with the issues of costs relate to cost benefit and cost effective analysis with regards policy changes, and having these elements as part of the evaluation process. That's the surmise of my take on the issue of costs. I do know that sometimes costs don't really capture, the costs are really the ticket price, and they may not necessarily capture the accounting costs and or the actual reimbursements, and some of that data is very hard to arrive at. But there have been a number of studies, particularly in the kidney transplant realm, trying to gauge cost benefits and cost effectiveness of various policies and interventions, much more so in the kidney as opposed to some of the other abdominal and thoracic organs.
So I'm mindful that reimbursement and billed charges often there's a big gap between those, and that most of the actual reimbursement rates are proprietary. So that's an issue which I suspect we will struggle with. But I did want to, cost benefit and cost effectiveness are not the same and require somewhat different approaches. Do you have any sense as to whether we should be looking at one or the other or both? Or is there any guidance that you could provide in that regard? And again, there are folks who are much more knowledgeable about economics and cost on the committee than I am, so I would ask if they want to add to that as well.
I appreciate that, Ken, and I would defer to your expertise.
Okay. Dr. Schlage, did you, anything there that comes to your mind that you would want to raise at this point?
No, this is good. This is fine. Yeah.
Okay. All right. Let me actually ask Alex if he wanted to state his question at this point, and then we'll proceed through some of the other questions that the committee raised yesterday. Go ahead, Alex.
Thank you, Ken. I want to start by thanking Dr. Odom for an extremely clear and illuminating review of the issues as they are framed in the statement of our task, and particularly because this was not something that NIH had originated. And I appreciate the interpretation and background provided. I have two questions. The first one is, you emphasized, and I think very appropriately, the issue of justice or equity versus utility in the context of organ allocation and use, and particularly in noting that recent JAMA letter and so forth, a set of issues that we are definitely going to look at. Do you take the word equity in the charge to refer to the problems that arise when either organ donation, organ procurement organizations or transplant programs feel that they have been treated unfairly by a change in the rules? And my impression, and you can correct me, is that the lawsuits that arose, the two lawsuits that arose around the issue of implementing or not implementing the acuity circles, reflected that sense of this isn't fair to us as programs, partly, of course, as surrogates on the transplant program side for their patients, but partly just because the programs themselves were worried about the implications for their own standing and economic survival and so forth. Is that also part of equity in the charge to us?
I have my take in framing Congress's intent starts off with the directives in NOTA and the final rule, which takes a patient-centric view of equity that's not necessarily constrained by zip code, region, transplant center, OPO, donor service area. So my take was within the context of what is stipulated in NOTA and the final rule. It's obviously open to other viewpoints and interpretation, and one can be more restrictive and more geographic in its application. But at the outset, it was framed by the general principles of NOTA and the final rule. I don't know whether that helps.
It does. Thank you. Yes.
Before Alex, let me just add, so with regard to the specific question and with regard to the committee's deliberations generally, I would interpret what you just said, that our North Star, to use that metaphor, should always be the patient and what is patient-centric. Would that be a correct interpretation?
I think that's fair.
Okay.
And the second is a question of just of information. And would you remind me, was this task assigned in the legislation to NIH? And given the role that HRSA plays in the transplant program, if that's the case, what concerns should we have with HRSA? And I guess it partly strikes me as curious that among the branches of the executive branch of HHS and so forth, the task ended up in your lap. I guess I'm feeling sympathetic to you, but given the wonderful way you introduced the subject, the committee is well served by it being at NIH. I'm just curious if you can say anything about that.
I don't know the circuitous route by which we ended up with the delegation. It was brought to my attention that a earlier NASTM committee had performed some work and a study for the transplant community, and NIH factored prominently in establishing that contract with NASM, and that was still open, and that seemed to be the vehicle that was used to get this show moving. That's all I know about it. And that last study was, I believe, in 2017, 2018, that sort of looked at donor interventional research opportunities and possibilities in the deceased donor.
Right. I had no difficulty seeing why that was an NIH study. The open contract avenue seems an explanation. Thank you very much.
So there were a number of questions yesterday and significant discussion about equity issues. Let me just ask the committee if they would like to, since we're talking about this at this point, if they would like to weigh in on other questions at this point under this general rubric of equity.
Hi, this is Yolanda Becker, and thank you, Dr. Kaiser. The question arose as to whether, in terms of equity, are we being tasked with equity in terms of access to the waiting list, or equity for transplant once patients make it to the waiting list, which is two distinct points in time?
Are they related?
Yes, very much so.
Part of the continuum.
Right. So the question is, can it be dichotomized, or should it be dichotomized if it's part of the continuum? I don't know. I would have to defer really to you as experts and your judgment with regards to that. But clearly, getting referred, then getting evaluated, and then getting waitlisted, and hopefully getting an organ, there's many a slip between the cup and the lip in that continuum.
So this is Kevin Abbott. I'm a bit hesitant to raise an issue, but it's obvious that we talked about living donation right at the beginning of this meeting, and clearly it plays a bigger role in kidney than in other organs, and a bigger role in pediatrics than in other age groups. So I'm biased, of course, because kidney is my organ, but it is a little bit different. So in achieving equity, obviously there have to be a somewhat different approach, taking into account the greater reliance of living donation in these particular circumstances. And sorry to point out an obvious point, but that seems to be one difference perhaps between the organs that might be taken into account.
Thank you, Dr. Abbott. Other, Dr. Becker, did that sufficiently answered?
I don't know whether I satisfied Dr. Becker, but
Thank you. It is certainly, I think, a difficult question to answer, and certainly we'll have deliberations in the committee concerning this because, as you know, access to the list is certainly a large hurdle to even be referred and then subsequently to receive a transplant. So I'm sure these are things that we'll deliberate on. If there's not an absolute directive from the NIH, I'm sure this is something that we will discuss and in the confines of the committee.
thank you.
I think from my interpretation of that, this will require really both components, as Dr. Odom pointed out. I mean, it really is a continuum, and one can decide, where and how to break down between the listing and actually getting the organ. But the end product here at the end of the day is receiving an organ.
And I might add, in this continuum, the cost issues may weigh in because, there are costs that are encountered if one doesn't progress through the continuum if you have an organ disease and are eligible. And how do you account for the costs if you are stuck on dialysis and not getting referred versus the cost of getting referred and getting a transplant and so forth. So there are all these cost trade-offs in terms of benefits and effectiveness.
So if I may, we didn't talk about this yesterday, but I'll defer to the transplant experts. It seems that the continuum doesn't end with transplantation because there's so much care that occurs afterwards. And we didn't talk about that yesterday, but it seems as if we need to factor that in as well, particularly since outcomes also drive how people think about eligibility. And we're actually thinking about a cycle in a certain way, as opposed to just a continuum.
And if we use the patient and what's best for the patient as our guiding light or as our North Star, so to say, then I think the answer to that, Jewel, may be clearer. So, and I would just note, in general, I think the committee is happy to use its judgment on some of these things, but part of what this discussion is about is to find out if there are clear boundaries or areas that NIH has thought about and wants to put up fences around what we do, so to say. Hearing none on several of these issues, I think the committee will be happy to proceed using its collective best judgment. So let me, again, Rebecca, let me turn to you. What on that, on the questions that we passed along, have we not touched on so far?
Sorry, I had to scroll over there and unmute. I think that you have covered most of what we had outlined for NIH.
So let me ask the committee, having reflected on our conversation from yesterday over the course of the evening and this morning, are there additional questions that you might want to pose to our NIH colleagues at this point? Sue?
Hi, this is Sue Dunn, and I think we were discussing yesterday maybe a little more clarification about the language regarding turning the language from discarded organs to maximizing organ usage. And I wasn't sure where that kind of ended in terms of better guidance to the committee to have that additional language included in the statement of task.
And Dr. Odom, just to add to that, issue was raised yesterday that some in the donor community may view the term discard as somewhat disparaging, and encourage that alternative language be used in the statement of task. I think certainly from the committee's perspective, that is how we will proceed as we approach things. I guess the question is, what are the logistical hurdles that would have to be addressed to change the verbiage that's already in the contractual language at this point, and whether that's something that we need to do, and some of that may actually be a discussion offline as well. Actually, Andy, do you want to weigh in on that at all at this point?
It's a relatively simple thing, I think, that we can do if we agree to doing it.
I would think that my colleagues and I would agree with that recommendation.
It seems to me it's sort of two sides of the same coin. It's more sensitive terminology.
Right.
All right, so we can proceed along those lines, based on at least my prior experience with this, something like that can be done relatively simply, and
yeah,
we'll just work it out in the background. Does that adequately respond to your?
Yes, it does. I think in the version of the statement of task that I have from the booklet, that entire additional language isn't actually in the statement of task. So I think the question around the language is one part, but also having it formally included, unless I don't have the most current statement of task. So it's probably a little more about maybe administrative thing. I think the intention, I'm glad to hear, is that there'd be an emphasis on maximizing donation of, or maximizing utilization of the organs.
Right. So we'll proceed along those lines. Elisa?
Yes, hi. I do have a question with regard to the statement of task as it pertains to reducing inequities. Currently, the statement states measures to be taken to reduce inequities in organ allocation affecting socioeconomically and disadvantaged populations. That's very, that's very important. My question is whether we should broaden that scope to include other groups, such as disparities or inequities by sex or sensitization level. There can be a whole geography. There are many other factors to consider in addition to socioeconomic status. And I just wanted to check with you to see if we should be more inclusive. Thank you.
Thank you, Lisa, for your comment and or an ability to be broad. I agree with you. Gender, age, pediatrics versus less than 65 versus greater than 65, educational status, rural population, sensitization, all these historically there have been certainly reports of desperate outcomes in these groups. So I'm more inclusive than I am exclusive, so I would support that. And it might have some impact on allocation modeling and simulation, which tends not to address a lot of those issues up front when the assumptions are being made in the models, but tend to address those issues after implementation, and we discover unintended consequences. And perhaps with your question, the committee should visit or revisit whether it might be important to include an ethicist in the development of some of these simulation allocation models, and towards what the expectation would be per nota in the final rule. And for example, 20% of such a population should get a transplant. And if these things are put up front, perhaps when policy gets implemented, it might have an effect on ratcheting down some of the unintended consequences.
Thank you.
Let me add an extra wrinkle to what was just discussed, and a question that was specifically posed yesterday by one of our committee members who is not able to, who is not on the call at the moment, but who works at a very large and busy safety net system. Well, San Francisco General Hospital, for those of you who know it. You know, it's both a very busy safety net as well as a trauma center. And they not infrequently treat undocumented immigrants who may either be on the donation side or on the potential recipient side. And do you have any particular guidance or constraints that the committee should be aware of in thinking about how we address the question of undocumented? And the committee is aware of all the political issues in that regard over the last few years. So
I really would defer to OPTN policy with regards to some of these issues, and foreigners, another category, you know, what foreign donors or on the recipient side. And there may be policy that speaks to this, and it's out of my bailiwick. So I would defer to that. I would defer to existing policy if such exists with regards undocumented citizenship, foreign.
I'm taking from that, though, that it's not a priority off the table.
I would defer to your judgment, the expert judgment of the committee, and perhaps we may get some congressional input with regards to this, but I think you're the experts, and if you feel that this should be on the table, then I think it's well within your purview to look at.
Okay, thank you.
Ken, I'll just note that Mario has his hand up.
Okay, Mario?
Thank you. So my question is related to Dr. Becker's question from earlier and expands on it a little bit. So when thinking about organ allocation, one might take a sort of a narrow view and consider allocating a given amount of available organs among a given set of candidates, recipients. However, our discussion earlier prompted by Dr. Becker's question and also by Dr. Odim's remarks about, possibly the waiting list is affected by, disparities in access to it. And so on the demand side, forgive me for using economics language, on the demand side, we should probably not take that as a given, but consider whether everyone who might benefit from a transplant has actually a chance to be included on the waiting list, and so including both efficiency and equity aspects to access to the waiting list, and also on the other side, on the side of organ availability, many inefficiencies or even dilemmas in allocating organs might be relaxed if the overall supply of available organs expands. So should we be adopting this broader view of the allocation problem to include procurement that, starting with organ donor registrations at the DMV and following that, that path? So I guess my question is about the scope of the allocation. So how should we view, the task of focusing on allocation, narrowly or more or broadly?
I don't know if any of my colleagues want to take a stab at that.
Jonah, this is Neil. I can try to take a stab. I think from the perspective of the thoracic community, at least from the lung, given the waitlist mortality, despite increases in the number of transplants, I think a broader perspective on this question would be appreciated. That's how I see it.
Similar to my perspective as well, that a broader one could be beneficial.
Dr. Parsa, we're not able to hear you.
I think I'm having issues with my microphone. I said my interpretation was the same, that a broader one could probably be beneficial, and one can clearly delineate, what's the broader part and narrower part, which then makes it from the policymakers easier to know what to implement or not. But while doing this, worthwhile analysis and study, I think being able to be a little bit broader in terms of ways to improve the number of people who get transplants is potentially worthwhile.
Thank you.
I agree with my comments, excellent suggestions. And I further reinforce Dr. Odim's excellent suggestion for an ethicist. So for example, is the broader goal, an attempt to restore as much of normal life expectancy as possible? This is implicit among some of the preferences for younger patients. What are the goals of this equitable distribution? That's really something for society to address.
Thank you. Again, committee members, other questions, nuances, things you'd like to see responded to at this point?
Ken, I also just wanted to note there was another question about bullet number 8 in the statement of task and self-reported donation metrics. This was around basically what CMS is doing now in terms of performance evaluation and how the committee should consider that during the study.
Yeah, and just to add a little bit to that, the landscape may have changed a bit with the new CMS regs in this regard. And the question, I guess, was maybe to state it most simply is, should we view things within the new landscape and again, take a forward-looking and broad view, or do you think something else was in mind?
Can you reframe the question for me again, Ken? I'm sorry.
CMS has weighed in with new regs in this regard, and which changes some of the what may have been in the original statement of task with regard to performance measures, and whether we should be looking at things in light of the new regs and take a forward-looking view, or not. I think that does that, and again,
yeah, that clarifies it.
Yeah.
I think, with the new regs, you should probably be taking a forward-looking view. I think what is most important is that the OPO metrics and incentives align with transplant center metrics and incentives to optimize organ utilization. I think the most important component is that both stakeholders are rowing in the same direction with regards incentives and metrics. They're aligned, which has not historically always been the case.
I think that some of the committee members made that point yesterday, and actually let me open it up to the committee. I don't recall exactly who raised that yesterday, but whoever did, or the multiple folks that may have weighed in on that, does that sufficiently address the question, or do we need further clarification there?
This is Sue. I think from my perspective, that gives some clarity, and appreciate the comment about alignment.
I agree as well. Thank you. That's very helpful.
Okay. Charles, did you have a question?
Yes, in sort of that same vein as we're talking about the scope of our deliberations, we spent a lot of time yesterday talking about specifically about the statement of task, and I think we spent some time looking at the 10 sort of bullet points, what they covered. I think early on in the meeting it came up that the majority of those bullet points related to organ allocation issues, and then we were going back reading the first paragraph of the statement of task in the second sentence. The first sentence was mainly all about allocation issues, but the second sentence in the statement of task, the one that says the committee will examine the gaps, barriers, and opportunities for improving deceased donor organ procurement, allocation, and organ distribution toward optimizing and increasing the quality and the quantity. I think there's a lot of substance to be looked into in that regard that certainly directly relate to the number of patients we can transplant. And I was wondering if how that fits in with the original congressional language. If we looked at that issue in depth, would that be number 5, such other issues as may be identified? It certainly seems to be in our statement of task, but I think some of the committee members, had a question about do we look into the entire system, organ procurement side, the whole continuum, given that wasn't specifically tasked from the congressional language.
I think you're right. This falls into the 5th bucket of bullet from the congressional request under the other category.
Thank you.
Yeah.
And I take from that this is one of those areas where the committee should exercise its judgment as to where to proceed.
Yes.
Other questions, comments? And I'm at a little disadvantage in that I can't see who may have their hand up, or if there are any other questions from outside of here.
Sure, Ken. No other hands are up, but we do have a couple questions from the public audience. Should I take a minute and read those?
Yeah, we have a little bit of time here, so why don't we go ahead and hear those.
Okay, the first one says, I would like to know if organ donors have been able to donate their organs if COVID positive, and have recipients been able to obtain the transplant if they have tested positive for COVID?
there are probably a number of transplant folk on the call that could probably respond to that. Certainly Brian Shepard will have the numbers, but from my knowledge, both the donor and the recipient are tested peri-transplant, and if you're positive, it's the no-go. I don't know if that answers the question, but it's a no-go right now, based on the science.
Okay. And I suspect that that's a topic that will be discussed further by the committee as we proceed and as the information about COVID continues to evolve.
Right. The vaccination issue may change that. And so it's a moving target as to what will happen.
And that was part of what I was referring to. So, Rebecca, what was the second question?
Sure. I think some of these have sort of been covered, but I will go ahead and just read them since we do have a little time. One of them says, under equity, financial requirements of a transplant center have significant effect on the ability of patients to be transplanted. And will the committee take that into consideration?
I think let's note that question as something for the committee to further consider as it thinks through its charge and as it proceeds. I don't think we can offer a definitive answer at this point. Anything else, Rebecca, in the queue there?
Yeah, I think somebody was asking in relation to the CMS new regulations that if the committee adopted a forward-looking approach, would we be able to use historic data? Would the committee be able to use historic data? And I think the answer is yes.
Yeah, I think the issues there would be in the details, and I mean, at first blush, it seems like a yes, but we'd need to explore the particulars.
Sounds good.
Any other questions?
We've got some comments about, resources the committee should look at, and we'll be certain to share those.
Okay. Is there anything else that I'm mindful that the time of our NIH colleagues is precious, and so I don't want to keep them longer than necessary. Are there any other questions from the committee or any other issues that have been raised that we need to direct to Dr. Odim and his colleagues at this point?
Can I have one additional question if I could ask?
Absolutely.
We are aware of the issue that arises when people who are not U.S. citizens but are long-term residents seem to face a situation of imbalance. They are eligible, as we all are, to become deceased donors, but the way our healthcare system is managed and financed, they may not be eligible for receiving organs. There's another category that's related, which is non-resident non-citizens who come to the United States, particularly because they want an excellent transplant. And many of our transplant centers are, of course, world-renowned. And those centers then put them on the waiting list, and they may receive a deceased donor. Is this potentially within our discussion of equity?
I don't know what the current rule is, but it's my understanding that each transplant center and or program can transplant up to 5 foreign nationals. Now, that may have changed over time.
And my impression is that we now rely on a counting system, that is to say, reporting system rather, that these are supposed to be enumerated in the UNIS data rather than there being an arbitrary number. But all of that, so there is a recognition of this, both by that older policy, I believe it was an older policy that you're referring to, and the current reporting. But the suggestion there is that there's something of concern. And I'm just wondering whether our understanding of a patient-focused allocation system would properly take that into account.
Yeah, it's quite complicated. Presently, there are so many concerns about looking inward, regionalization, transplanting by zip code, not letting organs escape, and then to add the other layer of foreign nationals might really exacerbate a situation that we haven't even taken care of the local nationals. So,
Right.
Again,
you would not think that a discussion of this issue would be out of bounds in that it is a concern if we're thinking of, as the first report from the committee that advised HHS in establishing the regulations and so forth to implement NODA, stated at the time, our organs are a national resource, a national public resource. And I guess the concern arises in that these patients are not people slipping over the border in Texas or something. These are people flying in, being put up very comfortably because they are wealthy people who are coming from countries.
Sure.
And they can also be generous people, obviously, to the centers that manage to transplant them. Anyway, it's just, it's an issue that I think we might discuss, and I take your answer to be that would not be out of bounds.
No, I think I defer much to the broad expertise on your committee to look at these issues, and confident that you'll come to a resolution with regards to that.
Thank you.
Yeah, I agree too. I think that at the end of the day, a lot of what this committee will end up doing is really identifying different areas of problem and issues. I don't think, obviously, that within the time frame and limitations of the study that there's going to be resolution of everything here. So anything that an expert committee panel views as a potential issue to bring up in the broader context of all of this, at least from my perspective, seems fair game, because at the end of the day, it's just identification of issues as viewed by an expert panel. So I think there's room to be fairly broad, at least in delineation and identification of problems and issues.
Thank you for that.
So if there are no other questions from the committee, we are pretty close to where we had hoped to be at this point, maybe slightly ahead of schedule. But I want to thank you, Dr. Odim, again for an excellent and very clear presentation. I want to thank your colleagues, Dr. Abbott, Dr. Parsa, and Dr. Agrawal for their participation. If there's anything you would like to bring to the committee's attention as we move forward, we would welcome it and look forward to having an ongoing dialogue with you as things proceed. And if there are no further comments, we will move ahead with our next speaker.
Thank you, Ken. Appreciate the invitation, and we all look forward to working with your group.
All right. Thanks, John.